Can you all see my screen?
Yep.
All right. Well, good morning, everyone. For those of you who don't know me, my name is Lara, and I'm one of the Neurology PGY3 residents, and this is my case. So this is a patient I took care of on my pediatrics rotation. So he's a 7-month-old male with a past medical history of lissencephaly, focal epilepsy, and infantile spasms, who presented with a 3-week history of failure to thrive and abnormal movements. And so per his mom, he'd been refusing feeds, was vomiting, was lethargic, and was losing weight. And at the same time was noted to have these abnormal movements characterized by back arching, head extension, and intermittently a high-pitched cry. And this was clearly different when compared to his prior seizures, which were characterized by left facial twitching and left arm stiffening. And for his seizures, he was on lacosamide, levetiracetam, and for his infantile spasms was on vigabatrin, and a second round of ACTH, which had been weaned over the course of 4 weeks. So on presentation, he was tachycardic, he had labile blood pressures, intermittently destatting and requiring supplemental O2, was crying intermittently with that high-pitched cry, and had forceful bilateral eyelid closure, did not clearly respond to visual stimuli, and had, interestingly, orolingual dyskinetic movements. Was also noted to have some opisthotonus. His neck was hyperextended. He had increased tone throughout and had dystonic posturing with choreiform movements that were a little bit more noticeable in his right upper extremity and his right foot, as we can see here in this video. So clearly has opisthotonus, has neck hyperextension, and don't know if you can notice the orolingual dyskinesias and choreiform movements a little bit more pronounced on that right side. And so in thinking about what could potentially be causing his presentation in someone who's immune compromised and presenting with labile blood pressures, we worked him up for meningitis, we worked him up for adrenal insufficiency, with him coming down on ACTH for a second time, and he had extensive workup with inflammatory markers, a cortisol level, a lumbar puncture, all of which were unrevealing. And he was monitored on video EEG, and there was no electrographic correlation with any of his abnormal movements. So we went on and got a brain MRI, and this is his T2 sequence here, which shows his lissencephaly, which was known about him. So it's agyra, pachygyra pattern. He has some volume loss. And interestingly, his T2 hyperintense signal in his midbrain and his bilateral thalami and bilateral globus pallidi. And so in thinking about what could potentially cause this presentation, obviously we considered metabolic and genetic etiologies, but in discussing this with my attending on service at the time, the possibility of vigabatrin toxicity was brought up. And so vigabatrin is one of the first-line treatments for infantile spasms, and it's an irreversible inhibitor of GABA transaminase. And there's an entity known as vigabatrin-associated brain abnormalities on MRI. Usually it's asymptomatic, tends to be prevalent in 22 to 32% of infants who are on vigabatrin. There's been a dose-dependent effect reported in the literature, and our patient was on a relatively high dose of vigabatrin. And what we tend to see are these T2 hyperintensities and restricted diffusion in the basal ganglia, in the thalamus, the cerebellar dentate nuclei, and in the midbrain. Unclear why there's a predilection for those specific regions in the brain, but there's been suggestions that maybe this reflects regional abnormalities in GABA metabolism. There's the peak effect is 3 to 12 months after initiation of vigabatrin, and there's typically partial or complete reversal on discontinuation of the medication. So looking into the literature, it appears that there are a few case reports of symptomatic vigabatrin-associated brain abnormalities, and these infants have presented with encephalopathy, extrapyramidal symptoms, dysautonomia, and respiratory failure. And they typically present weeks to months after initiation of the medication. Our patient had been on vigabatrin for about 2 months when he presented to us. The pathophysiology is unclear. There's potential potentiation of toxicity with concurrent hormonal therapy, such as ACTH, which our patient was taking. And there have been a few fatal cases where they've done some autopsy studies and what they found is spongiform vacuolation of the white matter tracts, as we can see here in H&E staining of the basal ganglia and in the cerebellum. And this appears to be consistent with what they found in preclinical studies looking at rodents who have received vigabatrin, and they've found intramyelinic edema, essentially. The outcome is variable. It's typically favorable with early discontinuation of vigabatrin. Some infants have had residual symptoms, and so one of the questions that's been brought up is, are we just unmasking the propensity for a movement disorder? And fatal cases, as I've mentioned, have been reported. So going back to our patient, we treated him with clonazepam and gabapentin, but it really wasn't until we discontinued his vigabatrin and ACTH that he started to improve. He was hospitalized for about 2 weeks, and by the time of discharge was smiling, vocalizing, his tone had improved, and he was moving all his extremities fully, and we didn't see his hyperkinetic movements anymore, and he had good PO intake. Eventually, he was discharged home on a ketogenic diet in addition to levetiracetam and lacosamide, and is currently being followed in the outpatient clinic. And that's it for my case. Thank you.
Thank you, Lara. That was great. Great job. All right, so it's my honor to introduce Dr. Miles Berger. Miles is an associate professor of anesthesiology. He's a graduate of Columbia University, and then his MD and PhD at the University of California, San Francisco. Then he came back to the East Coast to do anesthesia at Duke, where he's currently a faculty member. Miles' work involves cognitive changes, including both delirium and dementia following surgery, and the CSF and blood biomarkers associated with those changes. As such, and for those who may not be aware, Miles is a worthy successor to the long history of research involving cognitive dysfunction after surgery, especially cardiac bypass, that has been a staple of Duke anesthesia history, originally pioneered by Mark Newman and perhaps someone before him. Miles is the author of over 50 peer-reviewed publications. He is also famous for his ability to do lumbar punctures, which are not only painless, but enjoyable. He's the associate editor of the Journal of Alzheimer's Disease, and he's the American Society of Anesthesiology's representative to the American Geriatric Society. He's the PI of an NIH K-76 and a Ruth K. Broad Foundation grant, amongst others. So I'm pleased to welcome Miles to Neurology Grand Rounds today. Sorry about that. The title of his talk is Alzheimer's Disease, Anesthesia and Surgery, Perioperative Care as a Stress Test for the Aging Brain. All right, Miles, take it away.
Great. Thanks so much, Rich, and a pleasure to be here. Let me share my screen. Can everybody see my screen now?
Yep.
Okay, great. So it's a pleasure to be here. I've had learned a lot from and interacted with many members of the neurology department over the years. Jim Burke and Luke James and Dave McDonough were some of the people that got me going on this work initially. And then Rich, certainly, and Andy, as well as Andy Spector, have been collaborators, and Carol Colton's been an important influence as well. So it's great to be back with you all this morning. So for those who haven't had a chance to look yet, the groundhog did see his shadow this morning. So we do have another 6 weeks of winter. That's my news announcement. In terms of conflicts of interest, I have some private legal consulting income related to this topic, some material support in terms of an EEG monitor loan for a study I won't talk about today, part of the geriatrics task force for the American Society of Anesthesiology, no corporate or pharma funding. So brief outline on what we'll talk about today. We'll go over the background of periop neurocognitive disorders, which definitely has a history here at Duke, as Dr. O'Brien mentioned. We'll talk about post-op cognitive dysfunction and CSF AD related biomarkers. We'll talk a little bit about intraoperative EEG to identify delirium and patients with cognitive impairment before surgery. And then we'll do a little conclusions and Q&A. Rich is absolutely right that this work really started at Duke with Mark Newman, who was our chair when I applied to residency here back in, I guess, the fall of 2008. And he really put this on the map with this paper that came out in the New England Journal back in 2001. And what they did was rather simple but important. They did a cohort study in a bunch of older adults, and they did cognitive testing before and after surgery up until 5 years after surgery. And what they found is if they classified patients based on who had cognitive dysfunction early after surgery, right here, I don't know, can you guys see my mouse? I'm not sure if you can or not.
Yeah.
Yeah, okay, great. So they separated the folks into those who had cognitive dysfunction right after surgery at hospital discharge versus those who didn't. So not surprisingly, these two groups are different by definition. What's interesting though, is that there's then a mid-course correction where these folks who were impaired there recover back to baseline roughly by about 6 weeks to 6 months. But then 5 years later, they showed worse cognitive decline than folks who didn't have that dysfunction early on. And so in this paper, they proposed that maybe something was happening during cardiac surgery that injured the brain and that resulted in cognitive dysfunction right after surgery. But the patients were able to recover from that in the intermediate term, but then it still came back sort of later on. This general finding of these three sort of periods, the early dysfunction, the mid-course correction, and the long-term decline, was basically shown again more recently by Sharon Inouye and colleagues of the SAGES research group in Boston. And they did something pretty similar, but this time in non-cardiac surgery. And they split patients into those who developed delirium after surgery versus those who didn't. And they found, as a lot of other people have, the patients with delirium started at a little bit lower global cognitive performance before surgery. They have this initial drop that's greater than the people who didn't have delirium. They have this mid-course correction where they return to their baseline, but then they have a long-term decline that's possibly worse than that seen in the patients without delirium. So these two studies have this same triphasic pattern, but neither one really answers the question of what's causing this. And there's at least two general possibilities. One is that anesthesia and surgery damage the brain and cause all of this. And that's certainly the initial interpretation, I think, from the Newman paper. A second interpretation is that there's something clinically different or clinically latent that's different about the brains of the patients in the two groups in each study. And anesthesia and surgery is really just unmasking some latent vulnerability. Maybe these patients are, for example, amyloid positive, but don't have MCI yet, or have some other latent neuropathology. And that question, what causes this, is really what's driven the field ever since. And I think we're still trying to figure out now, 20 years later. So just a brief sort of time frame description of POCD versus delirium. So, emergence delirium, we typically see as anesthesiologists in the PACU. Then, within a couple of days after surgery, people often see older folks with postoperative delirium on the floor or in the ICU. Certainly, there's a lot of it there. And then POCD has always been thought to represent a dysfunction that's present weeks to months later after the initial postoperative recovery has already occurred. It's sort of what's left even after that initial physical recovery is the concept. Now, these are complicated disorders. There's a lot of different things involved, certainly when somebody's having anesthesia and surgery. There's a whole bunch of work that suggested that anesthetic drugs and surgical stress may increase the production of amyloid beta monomers and increase their incorporation into plaques. Work showing they increase the amount of tau produced and its phosphorylation within neurons. And we'll come back to that in just a moment. There can be changes in cerebral oxygen delivery. Of course, we're treating the patients with anesthetics that we don't completely understand how they work. There's all sorts of physiologic changes that are happening. There's an inflammatory response to surgery and a counter-inflammatory response. And then during many types of surgery, you have vascular mechanisms that can get involved if you're opening blood vessels or inducing thrombi. And then there can be blood-brain barrier dysfunction induced both by the surgical stress and inflammation, as well as by the anesthetic drugs themselves. So it's a complicated problem. There's a lot going on. The first part of the talk today, I'll focus on these AD-related mechanisms. I won't go through all the papers on this, but suffice it to say that both in vitro studies as well as mouse studies really showed in a number of different studies by different groups that anesthesia and surgery could accelerate these processes. So when I was coming through residency here, it sort of struck me as a natural possibility that maybe some of this acceleration of AD pathology had something to do with the cognitive dysfunction that Mark Newman and others were observing after surgery. And so there's a number of different ways one can study these topics. In this talk, in the first part, we'll focus on cognitive testing and CSF markers. And then in the next part, we'll talk about EEG. So I'm going to tell you about the results of a study that just got published, Markers of Alzheimer's Disease and Neurocognitive Outcomes After Perioperative Care, or MEDCO-PC. I understand we need to work on our acronyms. I understand this is not a real word, but I ask you to bear with us nonetheless. So the primary outcome of this study was to look at the correlation between the perioperative change in CSF tau levels and the continuous cognitive change index from before to 6 weeks after surgery. And we did a power analysis and saw we needed 108 patients to detect a Spearman correlation coefficient of 0.3 or higher, a low moderate correlation between cognitive change and CSF tau change if it were to occur. Our inclusion and exclusion criteria, we enrolled patients age 60 and up, having major non-neurologic, non-cardiac surgery, at least for 2 hours, scheduled for at least 2 hours. So this means folks having orthopedic surgery, urologic surgery, gynecologic, plastics, a variety of general surgery approaches, and some thoracic surgery as well. They all had to be English speakers because our test battery is only in English right now. And we excluded pregnancy, prisoners, anybody on chronic anticoagulants that would impede our ability to safely do an LP, and anyone with severe claustrophobia, because there was also an MRI component to the study, although I won't have time to talk about that today. And this just came out actually online yesterday, so pleased to be able to tell you about some fresh data. So it's a little bit of a complicated study. There's a number of different things going on. Patients underwent cognitive testing with a full neuropsych test battery before surgery, and then had blood and CSF obtained before surgery. And then 24 hours later, we screened them for delirium, blood, and CSF, continued delirium screening for the next 5 days, as long as they were in the hospital. And then 6 weeks later, we repeated the cognitive testing and CSF sampling. And the goal of the study is really to look at the correlation between the cognitive and CSF data. And so we had 110 patients who returned for the 6-week visit. They were about 69 years old on average, mid-60s to mid-70s for the most part, a few 80-plus-year-olds. 90% Caucasians, about 9% African-American. There are average Duke surgical patients with a BMI in the high overweight range, close to obese. The average patient was college educated, but there was significant variation. We actually had some folks who hadn't even finished high school. We had some folks who were PhDs and Duke faculty. So significant variance in education range. And they were by and large cognitively normal. I think we only had 1 or 2 patients maybe who had a pre-op MMSE below 25. And so what did we find in terms of AD biomarkers? Well, we saw no change in amyloid from before to after surgery. Now, there is a significant variance among patients, and that's not surprising in a cohort like this of older folks, some of whom will be amyloid positive and some won't. But there wasn't really any significant change either at a group or individual level in amyloid over time. You can see the p-values nowhere close to significant. And then we looked at tau, and what I'm showing you here, the black line with the error bars, that represents the group median, and the error bars represent the median absolute deviation. It's sort of the non-parametric version of a standard deviation. The colored lines above represent trajectories of individual patients who were more than 1.5 times the interquartile range at any time point. So in other words, we're showing you the outliers here in individual colors, and then the bulk of the patients are in this range. And I think either way, whether somebody's an outlier or whether they were here in the main group, what you can see is they by and large stayed flat. There's nobody who's showing a huge increase in CSF tau. That was very interesting to us because we had previously found big increases in CSF tau, 3-fold increases after neurosurgery in the ENT cases here, and others at other institutions had also reported big CSF tau increases after ENT cases. So it's interesting, we didn't see that at all. And we collaborated with the same lab from ADNI at UPenn to make these measurements. So there clearly doesn't seem to be a large group of patients having a tau change after surgery. In terms of the tau over A beta ratio, you see something roughly similar. Most people are down here pretty low, down at around 0.1. You have some people who start a bit higher, but they more or less stay where they started. Nobody's showing any significant change in tau over A beta. Now, we did see something interesting for p-tau, though, for phospho-182 tau, the isoform seen in Alzheimer's disease, where, again, the majority of the patients stay flat and don't change, but we did see a couple folks that had these big changes, big increases. And, you know, we're not quite sure what to make of that yet. The challenge with small n's like this is, you know, you never know, was it, you know, is that a real finding, or, you know, was there just something funny about those samples? We can't say definitively, but it is interesting. There were a number that showed a big p-tau increase. But what about the main question? Was there a correlation between CSF tau change from before to 6 weeks after surgery and cognitive change overall from before to 6 weeks after surgery? So in this population is an individual circle. The x-axis is their tau change over time, and their y-axis is their cognitive change over time. So for example, somebody here is 0 on the x, that means their tau didn't change at all from before to after surgery. Positive change means an increase, negative change, a decrease. And what you can see here is absolutely no effect. As I joke sometimes, it's one of my favorite things about science. It's okay to be wrong as long as you're completely wrong. And it's hard to be more completely wrong than we were here. The p-value is about 1. The rho Spearman correlation coefficient is almost 0. So it's very hard to argue that even, you know, that we might be underpowered and there might still be some effect. It's highly suggestive that even if you had 10 times as many patients, you still wouldn't see any correlation between these measures. And in the interest of time, I'll skip showing all the graphs, but I'll just tell you that these plots, if you put p-tau on the x-axis or tau over A beta or A beta, they're all basically the same and they show no correlation whatsoever. So in summary of this part of the talk, there's no group change in these CSF AD related biomarkers from before to 6 weeks after surgery in older adults. There's no correlation within or across individuals in these biomarker changes and cognitive changes after surgery. And if we look at as a dichotomous variable who had POCD, which our group at Duke has always defined as a 1 SD drop in one of 4 cognitive domains that make up that overall cognitive index. If you look at the people that did have that 1 SD drop, which is about 30% of the cohort, there's no difference in AD biomarkers in that group versus the others, no difference in values or in trajectory over time. So POCD, what Mark Newman was studying, does not reflect an acceleration of AD pathology, at least as far as we can measure by CSF biomarkers. So now I'd like to switch gears a little bit though, because if perioperative care doesn't represent an acceleration of AD pathology, the other possibility is, as we talked about before, is maybe it's just sort of unmasking something else that's there that's wrong with these patients. And if that's true, maybe we could detect that as abnormal brain responses to anesthesia. And so that brings up the next line of work here. A little bit of background to this, which I'm sure you guys will find interesting as neurologists. So the CNS is the target organ of nearly all of the sedatives and anesthetic drugs that we give. Yet it's the only organ system that we do not routinely evaluate in our pre-op clinic and pre-op evaluation. We are very interested in people's cardiac function, pulmonary function, renal function, but there's no standard for evaluating the CNS prior to surgery. Intra-op CNS monitoring is not currently standard of care, so you can definitely call this ironic. But part of that is that we don't really have a way to tell based on the EEG who's amnestic and who isn't. So it's not so ironic in that sense. Now, if you look at the EEG of a patient under anesthesia, this is what you see. This is a spectrogram. Not sure how many folks are used to seeing EEG data this way, but if you think about it, if you took a stereo equalizer and you've got low frequencies down here, like the bass, you've got high frequencies like a soprano's voice up here at the higher frequencies, that's what this basically is on the y-axis. You've got low frequencies down here, same as on the equalizer, and then you've got higher frequencies up here towards the top. Time is on the x-axis, and the colors indicate how much power or amplitude or how much signal strength there is at each individual frequency. And what you see under anesthesia, at least with the inhaled anesthetics and propofol, is a lot of power in this delta band, 0 to 3 hertz, and some power in this sort of 8 to 12 hertz or alpha band here. What's interesting, though, is about 7 years ago, one of our colleagues in Boston showed that this pattern actually changes with age. Older adults don't have that prominent alpha power, and this is a combination of spectrograms from a few hundred patients who got anesthesia for various kinds of surgery at MGH. And what they found consistently is that the alpha power diminishes with age, and it really kind of disappears by around age 65. So when I first saw this data, I was sort of immediately struck by, this is right around the age range when we start seeing an increase in delirium in older patients. And so I wondered, did this alpha band disappearance have something to do with that? And was that a marker of some brain vulnerability? So we teamed up with some folks in cognitive neuroscience here, Marty Waldorf, who's a professor of cognitive neuroscience, and Charlie Giattino, who was his grad student at the time, and started doing 32-channel EEG recordings in about 15 patients here. And then we did something called BIS EEG recordings, which is a frontal montage of just 3 or 4 electrodes that I think is used perhaps sometimes in the neuro ICUs here. And we had a group of 15 patients who had these 32-channel recordings. Again, 60 to 80 years old, et cetera. Pretty long cases, over 4 hours here. And here's what we did. We grouped the frontal 6 channels into an ROI, and we measured the amount of power in different frequencies in that range. What we found was a nice, reasonably good correlation between alpha band power and pre-op cognitive index. So in other words, people that had high alpha band power during anesthesia tended to do pretty well on the pre-op cognitive test, and people with low alpha band power under anesthesia tended to do poorly on the pre-op cognitive test. And this is data just showing that in the second cohort of patients who had just the frontal EEG, we saw the same pattern, slightly different effect size, but same direction, same basic finding. So this was interesting to us because it suggested that we could figure out how smart somebody was or how well they were likely to have done on cognitive tests without assessing that before surgery, in part just by measuring how their brain responds to anesthetic drugs in the OR. And if you look at the extremes, this is a patient with poor pre-op cognitive function. This is one with good pre-op cognitive function. And this is the topogram or topography of alpha band power. During anesthesia, you see this nice frontal alpha pattern here in somebody with normal or good pre-op cognitive function. And you see a complete absence of that pretty much in the patient with poor preoperative cognitive function. An impressive effect there. This work has since been replicated by other groups, including Emery Brown and colleagues, who also found that patients with low baseline cognition had significantly lower alpha power in this 10 hertz or so band. And then the question becomes, okay, well, we know that preoperative cognitive impairment is a risk factor for delirium. I showed some of the data from Sharon Inouye's group showing that patients with delirium actually had lower cognition before surgery. So another group looked at this, and they grouped postoperative delirium and subsyndromal delirium, people with some delirium symptoms, but who didn't quite meet the diagnostic criteria. And they found a significant difference here in their relative alpha power over their frontal brain regions. And if they did an ROC curve, their alpha power was actually a better predictor of delirium than was age or MoCA scores alone. Pretty interesting. But there was a problem with this data as we thought about it more. Anesthetics affect EEG patterns. And in the data I've shown you thus far in that paper by Giattino, we didn't control for how much anesthetic the patients got. They all got a roughly general anesthetic dose, but still with variance among patients. And we thought that we couldn't really say that this was definitely, that these alpha patterns were definitely a reflection of cognition, because it could just be a reflection of differences in anesthetic dosage as well. And so we decided we needed to somehow control in the EEG for how much anesthetic the person was getting to sort of see a dose response relationship, if you will. And this is just another picture showing the patterns you can get from anesthetics. And this just shows that ketamine gives you a totally different pattern and would totally change how much alpha power you had. So this is part of why we think we really need to control for this. So before I get into this part of the talk, let me just give some brief definitions so we're all on the same page. So we'll talk a little bit about MAC. That's the minimum alveolar concentration. Effectively, it's the EC50 for inhaled anesthetics. It's the inhaled anesthetic concentration at which half of the patients wouldn't move in response to a standard surgical incision. The reason this term is important is we have several different inhaled anesthetics which vary in potency. This allows us to talk about what's an equipotent dose among them. It's sort of similar if you want to think about it like the fact that one glass of wine has the same amount of beer as same amount of alcohol as one beer and as one shot, if you will. Different potency, but same amount of total effect. And then there's the BIS, the bispectral index, a somewhat controversial device and monitor that gives you this process score from 0 to 100, where 100 is fully conscious, 0 is like a flatline EEG, like an asystole, and 40 to 60, we're told, is the target range for general anesthesia. Here's what the monitor strip looks like, and here's what the monitor looks like, giving you that processed index number. Now, I mentioned this is a controversial monitor because in part, the company won't provide the algorithm publicly. So we don't really know what exactly they're doing mathematically to the EEG signal to generate this number. And the studies that have evaluated this for whether if you use this, for example, does it reduce the rates of awareness under anesthesia, those are quite mixed. And if you look at the studies that have looked at does using this reduce delirium, those are also quite mixed and still actively debated. It's interesting for historical reasons, I think, because there were some folks here at Duke who did a lot of work on this. This is a highly used monitor at Duke. That's not the case at most other major American medical centers. For example, colleagues at Michigan, another strong place for anesthesia and neuroscience of anesthesia research, they barely ever use it, they tell me. Whereas here we use it on 30 to 40% of the cases. So much so that sometimes if somebody doesn't do it, it's common for another resident or nurse anesthetist or anesthesiologist say, how come you didn't put the BIS on? Even though it's not actually an ASA standard monitor. There's no legal reason one needs to use this monitor. So I had a question ever since I was a resident here about this, which is, if you think about it, you can have a low BIS, a normal BIS, or a high BIS, right? And then you can have a low anesthetic dose, a normal anesthetic dose, or a high anesthetic dose, right? And so normally we're giving a dose of about 0.7 AE MAC. We give some other drugs too, and so that's enough to make people not move and not remember things. And then we typically expect to see, you know, a BIS score of about 50 if we're giving that much gas. That's a normal anesthetic case. What was confusing to me though during residency is there were some of these patients who had a low BIS number despite getting a very low dosage of gas, only 0.2 MAC. And I remember actually Dave McDonough, who's, you know, a neurologist and anesthesiologist and was an attending here for many years. He was the chief of neuroanesthesia when I was coming through training. People used to ask him, they would page him when they had a patient who had this pattern and say, Dave, what does this mean? Is the patient having a stroke? And Dave would just say, it's fine, just keep going. Don't worry about it. But it didn't feel right to me. It felt like there must be something wrong with these folks because that was such an abnormal response. If you think about it intuitively, to me, this would be like somebody having half a glass of wine at a cocktail party, perhaps in the pre or post-COVID era, and then just passing out unconscious. That's a very abnormal dose response. So as I thought about this more, I thought we needed some way to quantify anesthetic sensitivity. And we came up with this acronym called the DARS. This was also an example of Mark Newman's influence. Mark was in the Army for many years, and so he loved acronyms. We have a lot of acronyms in the anesthesia department as a result. So the DARS is the Duke Anesthesia Resistance Scale, and we defined it via this equation that we wrote, a very simple equation that just scales the BIS by 2.5 minus the mean end tidal age-adjusted MAC fraction. So if you're wondering what's with this denominator, where does this 2.5 come from? We did a large retrospective study of about 17,000 anesthetics here at Duke. And the highest anesthetic dose a patient ever got on average during the case was 2.5 MAC units, which to an anesthesiologist is a just sick high dose of anesthetic. When I first showed this to my chair, he was quite surprised that anybody ever did this in clinical practice. So thus the denominator really measures the difference between the maximum possible anesthetic dose you could ever give a patient and the actual dose given to a specific patient, if you will. So it's the difference between the max versus what your patient actually got. And we're scaling the BIS number by that. And so there's that equation again, just to remind us. And if you go back to that table I had before, now if we think through it, we can see what happens to this DARS equation. If you have a low AMAC and a low BIS, the equation works out to give you a very low DARS number. And similarly, if you give a normal amount of gas, but you get a low BIS, or if you give a low amount of gas and you get a normal BIS, in each of these cases, your brain is not as resistant, if you will, to the BIS suppression effects of anesthetics. And so you get these lower DARS values. And so we thought intuitively, this must mean there's something wrong with these people's brains if they have lower DARS values. And so we teamed up with a number of folks here, Sandhya Lagoo and Shelley McDonald from surgery and geriatrics here, as well as my colleague Stacy Diner, now at Dartmouth, formerly of Mount Sinai, and looked at some cohorts of older adults who received anesthesia and surgery and had these data and had really good delirium screening data. That's important because, as we know, delirium can be missed a lot in clinical practice, whereas here they had trained research staff assessing for it, so it's unlikely they missed much. And so we did a study looking at patients with versus without delirium, and this is Mary Cooter, right, our statistician par excellence, who was the first author on that paper. And here's the distribution of the patients and so on at the two sites. And you see they're pretty similar, patients with versus without delirium. I didn't show it here, but there was a slight difference, barely statistically significant in the DARS between the two groups, with a lower DARS in the delirium group. And if you dichotomize the DARS at 28.7, then you have about a 4-fold increase in delirium risk in the people with a low DARS versus a normal DARS. And you can see a highly significant p-value there. And then if we did a number of different regression analyses to control for other things, no matter what we controlled for, there was always about a 4-fold increased risk of delirium in the patients who had this low DARS score. So to wrap up and make some overall conclusions, I think we've found some evidence that anesthesia and surgery probably don't accelerate AD neuropathology, at least insofar as we can tell based on CSF biomarkers, even in patients who had POCD in our study. That's reassuring, definitely. I've told you that intraoperative EEG alpha power correlates with baseline cognitive function, which itself is a predictor of delirium risk. And I've told you that the brain's resistance, or alternatively, if you want to think about it as sensitivity to anesthetic-induced EEG patterns, is independently associated with delirium risk in multivariable models from a 2-cohort or 2-institution study. And now some future directions. What these results don't answer is, what is the pathophysiology of delirium or POCD? If at least POCD does not reflect an acute acceleration of AD pathology, what does it reflect? Or what is causing some of our patients to have this cognitive decline after surgery or acute confusion after surgery? These results don't really answer that. And then the second question is, what is the neurologic basis of variations in alpha power or in DARS among older patients? And we've just submitted a grant on that that'll be reviewed, I think, in the next few weeks, so fingers crossed on that. That's a question we're very interested in, is what does that mean about the brain if somebody has a low DARS or if they have low alpha power? And then a third question is, what should we do now when we see somebody has a low DARS? I mean, we can see this in the OR, but there's no consensus yet on what to do about this. And another way of sort of stating that question is, you can think about anesthesia and surgery based on all the work I've told you today as sort of a stress test for the aging brain. And by that, let's think about the analogy to a cardiac stress test, right? When you have a cardiac stress test, say an exercise treadmill test, the that stress test is designed to see who has latent cardiac abnormalities, let's say coronary artery disease or coronary artery narrowing, that puts them at risk for a disorder in the future. The stress test isn't what causes that person to get an MI in the future. The stress test is a way to determine who's at risk for it in the future. And so I think these data suggest the same thing about anesthesia and surgery. There's sort of a de facto stress test for the brain in terms of telling us who's going to have a problem later down the road in terms of delirium, in terms of cognitive decline, but it's not actually causing that itself. It's perhaps just unmasking something that was there all along that was latent. At least that's our conclusion thus far. And so then our interest right now is really figuring out, what does that mean if you fail that stress test? If you have low alpha power or you have low DARS, what does that mean about your brain? What are the brain parameters, either based on CSF markers or neuroimaging or functional connectivity, that are associated with this failing of the stress test, so to speak? So with that, I'd like to thank our funding sources. I'd like to thank many of you who've helped with this work and all of our colleagues in anesthesia, many of our colleagues in geriatrics, Harvey Cohen and Heather Whitson, who've helped us obtain the funding for this work. I mentioned Marty Waldorf and the folks in his lab, the anesthesia CRU, Mary Cooter, who I mentioned before, and then definitely our patients. This was, when we started this work, I think people thought we were crazy. They thought we were crazy to try to do lumbar punctures before and after surgery in older adults who are already having major surgeries. Fortunately, we were able to do that with a lot of local anesthetic and with the support of our surgical colleagues. And I think that's an important thing to note about Duke. I'm not sure this could have been done at many other places. It really happened because of the collaborative relationships we have here across departments, not only anesthesia and surgery, medicine, geriatrics, neurology, et cetera. And these are all the folks who help do the lumbar punctures, recruit the patients, get the grants, and so on. So with that, thank you very much for your attention, and I'd be happy to take any questions that anyone has.
Thank you, Miles. Marvin, are you out there? Do you want to lead off?
I was wondering if it mattered exactly what chemicals are used for anesthesia.
Yeah.
Just saying it's anesthesia is kind of like saying it's alcohol. There's lots of different forms of alcohol and exactly what you drink.
Yeah.
Also, how about other chemicals that are used during anesthesia, like paralytics? And you all usually give a whole bunch of different stuff. I mean, it sounds like those might make a difference.
Yeah, thank you. That's a great question. So we actually had a nested RCT within the trial I told you about, where we randomized the patients to get inhaled anesthetics versus propofol for anesthetic maintenance. Those are the two predominant ways of maintaining general anesthesia, either propofol or an inhaled anesthetic. You know, theoretically, one could do it other ways, like with ketamine, for example, but that would be a very unusual anesthetic technique, partially because it would take the patients a long time to wake up afterwards. In that nested RCT, which we're working on writing up now, we saw basically no difference in cognition and cognitive trajectory between patients who got propofol versus isoflurane. And we saw no difference in CSF AD-related biomarkers between groups, A-beta, tau, or phospho-tau. So at least in terms of, you know, is TIVA better, total intravenous anesthesia with propofol? Our data suggests it's not. There, at least in terms of 6-week cognitive and biomarker trajectories, there is some work suggesting that propofol-treated patients may have better cognition early after surgery. But one of the challenges is that you're sort of comparing really apples and oranges there. The two drugs aren't dosed at all in the same way. I mean, one is a gas that people breathe in. The other is an IV medication. The gas isn't measured in milligrams or, you know, weight units. It's measured in a percent inhaled. So it's really hard to say in those studies, you know, is it really that propofol is better, or is it just that people got much more of one than the other? You know, more alcohol in the beer than in the wine, if you will, so to speak. In terms of your other question about paralytics or other drugs, there have been studies that have looked at different amounts of opioids. That largely hasn't found an effect, to the best of my knowledge. And then in terms of the neuromuscular drugs, neuromuscular blocking agents, that's very interesting. There is a new drug that has come out in the last, I don't know, 5 or 6 years in the US called Sugamidex. It's a very interesting molecule. It's sort of like a big soccer ball, and it's a cage, and it fits over the non-depolarizing neuromuscular blockers like rocuronium or pancuronium. So the nice thing about it is you can have a patient who's completely paralyzed on rocuronium or pancuronium. You give them this Sugamidex, and 5 minutes later, all the rocuronium has been sucked out of solution into these complexes where it can no longer bind to receptors. The reason I mention this is that the previous way we used to reverse these drugs was with anticholinesterases, acetylcholinesterase inhibitors, neostigmine, which from a pharmacologic perspective is effectively the same thing as nerve gas. It's an acetylcholinesterase inhibitor. And then we were giving patients glycopyrrolate as an anticholinergic to block the peripheral effects of it so they wouldn't get bradycardic and have asystole or something like that. So back to your question, I think there are some people now who think that if you treat the patients with Sugamidex rather than the neostigmine glycopyrrolate combo, that they're probably better off cognitively because you're not manipulating their cholinergic signaling and giving them an anticholinergic drug. I'm not aware that a study's been done on that though. But it's a great question. I think the bulk of the data in the field, I think, suggests it's not so much which specific anesthetic drug that the patient's got. And much of our thinking now is that it's more a result of the stress response to the surgery, the inflammation, and how that interacts with latent sort of neurologic variables.
Thank you. Joel, do you want to go?
Yeah, sure. Several years ago, Daiwai Olson and I did a little study in the neuro ICU looking at propofol use and BIS monitoring because we were thinking that, we're using a whole lot more drug than we need to, partly because of cost. But, in the clinic, we see a lot of people come into clinic, not only people that have been septic, but other people that had prolonged anesthesia and other things that have cognitive deficits after prolonged ICU stay. So I'm wondering if you've studied ICU populations where people get prolonged anesthetic as part of their stay there.
Yeah, that's a great question. Thank you. And nice to think about Dawai, who I remember here from when I was training in the neuro ICU. Probably one of the strongest patient advocates for quiet time that I can recall in the ICU setting. Back to your question, I think that so we haven't actually studied the ICU component. Most of these patients, but not all, did not go to the ICU. There's a junior faculty member in the anesthesia department now, Mike Deviney, who Heather Whitson and I and others are helping mentor, who is an attending in the ICU, predominantly the surgical ICU, who's very interested in that question. And there's a lot of work that's been done by Wes Ely and colleagues at Vanderbilt on this issue of sort of post-ICU syndrome or PICS. Wes actually wrote a nice book that I'm reading now, blanking on the name of it, but it's a sort of lay media, popular media book. And one of the first stories he has in that book is a patient who has a knee replacement, but the patient has a long, prolonged ICU stay. As you mentioned, the guy develops a postoperative pneumonia. He's in and out of delirium in the ICU, et cetera. He's sedated for a long time. And it's like a month before he gets out of the ICU. And then that guy really does have long-term cognitive decline and talks about not being able to do the things he used to be able to do mentally and so on. So that is a big problem, whether it's, the extent to which it's the drugs versus the ICU stay versus the immobility, the lack of all the trophic factors that our muscles produce from walking that are good for our brain. I don't know. Those are fascinating questions. And I hope that, Mike Deviney, our new faculty member, will be able to answer some of those for us in the future.
Thank you. Jeff Guptill.
Hey, Miles, great talk. Obviously a very complicated question to try to crack. Can you comment on the role of inflammation perioperatively on cognitive outcomes and delirium? I remember several years ago there's interest in specific markers like peripheral TNF alpha or CSF TNF alpha levels, and like patients having like a baseline cognitive impairment that was not hadn't been fully evaluated. They get some level of inflammation that then tips them over into delirium and then unmasks this cognitive impairment?
Absolutely. Yeah, thanks, Jeff. That's a great question. Yeah, that's something we're very interested in. We've actually just completed a study, but haven't analyzed the data yet that looks at that exact question. And so we did a study similar to the one I described, but about twice as large, about 200 patients, where we obtained CSF before and after surgery. We've measured a whole battery of CSF cytokines at those time points. And then we've also done flow cytometry on cells we've isolated from the CSF before and after surgery. And we're trying to correlate those things now. As you pointed out, this is one of the dominant theories now of what causes delirium and potentially cognitive dysfunction following anesthesia and surgery, and perhaps even in the ICU setting. But I think the thing that's been really hard to get at is, people often say, oh, it's neuroinflammation, and they measure serum IL-6 levels or something like that. But you're going to have higher serum IL-6 just from a bigger surgery and more tissue injury. Whether that's really crossing into the blood-brain, whether it's crossing the blood-brain barrier into the brain, we don't know. And that's why we've gone to the trouble of looking in the CSF to try to tell. So I hope that in the next year or so, we'll have an answer for you on that.
Thank you.
You were teasing us with that. I mean, because that is an issue about whether peripheral cytokines get into the brain or in which particular ones.
Yeah. I mean, I'll note that depending on which study you look at, there's some proteins that have pretty good correlations between the CSF and plasma, and other ones that don't. For example, albumin normally is much, much lower in the CSF, orders of magnitude lower in the CSF than periphery. Some of the complement proteins that we're interested in now, as far as inflammatory mechanisms, there's been a couple of papers showing no correlation between CSF and peripheral levels. That also gets into the issue of where are these things being made? Are they being, do we have inflammatory cytokines being made by microglia in the brain itself versus do we have peripheral cytokines crossing the barrier? All important questions we don't know yet, I think.
Okay, is that Andy Liu? It just says Andy. You're muted.
Thanks.
Hey.
Yeah, so it was very interesting to see that the ketamine caused the alpha band to disappear, but you said that without an alpha band, people have a higher risk of delirium. Is there any medication anesthetic that can improve or increase the alpha band that you're aware of?
Yeah, great question. It's something a few of us have thought about now for a little while, and the thought is, and I have a few colleagues at Columbia and in New Zealand that are doing a study to answer that question. They've nicknamed it the Alpha Max trial because they're trying to maximize alpha power. And their theory is that, we usually give a mixture of opioids and an inhaled anesthetic to maintain anesthesia during surgery, with the rationale that you need something that's a bit amnestic, but you also need some pain relief, definitely, for the surgery. And while you could do the case with either one alone, it wouldn't work as well. Opioids are not, strictly speaking, amnestic, and the inhaled agents aren't really great for analgesia either. So the reason I mention this is the idea behind the Alpha Max trial is that maybe why some patients are having too low of alpha power is an imbalance between how much inhaled agent versus opioid. And so if you give a little bit more opioid and turn the inhaled agent down, you can sometimes get the alpha power to come up a little bit. And so that's what they're trying to do in that trial. I don't think the results are available yet, but it'll be very interesting to see.
I think it'd be really interesting for us as an outpatient to improve that alpha band in general, to help prevent this delirium as well. So thanks.
Yeah, exactly.
Sina suggests propofol could do that, and I fully endorse propofol for pretty much anything. Does propofol max your alpha, Miles?
Propofol does cause an increase in alpha power. I'm not sure that again, it's hard to compare propofol and the inhaled agents because they're so different. I mean, it's not even like beer and wine. It would be like the equivalent of comparing a party where there was beer versus a party where there was vapor alcohol. It's just so hard to compare the doses. I mean, they both will induce alpha power. I haven't seen a study asking the question across a full range of concentrations, which can induce more alpha power propofol or the gases. So I don't know the answer to that.
Okay, well, we're looking forward. I mean, you're a young man. You've got plenty to contribute, over the next several decades in a very important area. The thought that, 35 years ago when I was starting, we didn't know what delirium was, and we still don't know what delirium was. Yet you'd figure somebody could have. It has to be related to some kind of cytokine gone haywire. It's a big problem, though.
Yeah, absolutely.
Miles,
Absolutely.
just on a more personal note, how, as an anesthesiologist, did you get interested in cognition in elderly patients?
Oh, sure. So it's funny. So I wanted to do something in neuroscience and clinical neuroscience ever since I was in college. I went to Columbia for undergrad, and Eric Kandel was getting a lot of accolades at that time, who subsequently got the Nobel Prize for studying the molecular mechanisms of memory. And so I was very influenced by that sort of line of work, even though I didn't have the background to really understand all the techniques yet. And I always knew I wanted to do something neuroscience related. And actually in medical school, had some trouble deciding between neurology, psychiatry, and anesthesia. Wound up going with anesthesia in the end, but could have just as easily went into neurology based on my interests. And so when I came here, I knew, before residency that I wanted to do something with neuroscience of anesthesia. And I knew that the department here had a long interest in this postoperative cognitive stuff. And so, just put two and two together. That seemed like a natural place to go in terms of neuroscience of anesthesia and perioperative care.
All right, thank you. And we'll have one last question. Anyone who needs to go can go. Sina, why don't you ask your question?
Well, yeah, I think that in general that many of the underlying cognitive pathophysiological factors may have some overlap in post-critically ill patients, particularly with underlying cognitive impairment, and patients with dementia or the elderly, undergoing anesthesia post-surgery. So I think that in general, as a new faculty member here, relatively new, I think it would be beneficial to study these patients in an outpatient setting and check cognitive function in labs on a serial basis every 3 to 6 months or so, and try to identify similarities underlying what's causing this.
Yeah, absolutely. I agree. I mean, so that would be sort of like a cohort study where you just have a large cohort of patients and you follow them serially with cognitive assessments, and then some of them naturally will need surgery and others won't, and then you could track, what effect that has. There's not been a lot of studies like that focused on the perioperative care experience. The closest thing I'm thinking of is there was a study in Oregon by Katie Schoening, who's also a neuroscientist and anesthesiologist, where there was a study that did the sort of regular cognitive tracking you're talking about. And then they were able to get data on who had surgery. And then they went back and analyzed all this data. I can send out the paper if folks are interested. And what they found was that the patients who had surgery in that study did have greater long-term cognitive decline. And interestingly, there was an additive or interaction effect with ApoE4. So, the best thing was if you didn't have surgery and weren't ApoE4 positive, then you were a little bit worse off if you had surgery or were E4 positive. And then the worst decline was people that were E4 positive and had surgery. But absolutely, it'd be great to do more of that kind of work here. And I'd be happy to chat
Miles,
with
could
more.
you send me that paper? I'll distribute
Sure.
it to everybody.
Yeah, absolutely.
Because, we talk a lot to our elderly patients and they trying to decide about their hip so that's a common thing that we deal with.
Yeah, absolutely. Absolutely. And it's a tough decision for older folks. There's two sides to it. I mean, one side is all the stuff I've talked about, but the flip side is, if you're immobile because your hip or your knee are bad,
Absolutely.
and then
Absolutely.
they get it fixed and you're able to walk
Yep.
a lot more, maybe you do a lot
100%.
better.
100%. 100%. All right, everyone. Thank you and be safe, Miles. Thank you so much. And we'll look
Thank you.
forward to hearing from you in the future too.
Thanks so much, Rich. Thanks, everybody.